but I'm pleased to introduce Dr. Alan Musil. He's the chair of psychiatry here at ETSU, and he's the medical director and senior vice president for medical services at Frontier Health. He completed his undergrad at Vanderbilt, and then his medical degree here at Quillen, and then his residency at the University of Kentucky. He's triple boarded in general pediatrics, child and adolescent psychiatry, and adult psychiatry. And so he's worked a lot to help provide access to kids and adolescents in our region to get psychiatry services, and he's done numerous talks on the topic of child and adolescent psychiatry, and so he's going to talk to us about anxiety and depression today. So let's
Yes, sir. And I'm not going to turn on the in-room speaker unless you all tell me that I need to. So if at any point my voice drops, throw a roll at me, and I'll turn it right back on. We're good from your standpoint? Okay. Okay, so first of all, I was sort of assigned to this topic, and what I mean by that is that there's two different talks inside of this. Usually I do an hour presentation on depression and an hour presentation on anxiety, but we're going to put the two together. I also plan to severely frustrate you by not diving into how to actually prescribe an SSRI. This talk is more about the A word up there at the top, how to approach, when to prescribe. Okay, if we end up with extra time, I'll talk more about how to prescribe this much Lexapro or this much this much that. This is not that type of talk. I'm trying to give you more of an overview. Okay, and I'm trying to set it within an office visit. Okay, so this is not child psychiatrist for 1 hour doing eval type of talk. Okay, everybody okay with that? Okay, here we go. So these are the objectives. I'm trying to pull a fast one on you right here where it says classes. A class is an SSRI class. I'm looking for you to come up with something besides just SSRIs. All right, so I want you to come up with 3 classes that can help with anxiety. Number 2, give me some reasons why you might medicate. Give me some side effects to SSRIs is bullet number 3. And the 4th one is basically don't use homebound. I'll preach all about that. Okay? They wanted me to come up with 2 measuring outcomes. Usually I just have to come up with 1. I'm hoping in 45 minutes you'll feel very comfortable with your answer. You may already have the right answer to both of these questions, but I'm hoping your comfort level will increase. Okay, so I'm going to read the first one to you. Starting a low dose of an SSRI for depression is a good first-line treatment for mild to moderate depression in a child. And don't answer that right now, but I'm hoping in 45 minutes you'll feel really comfortable with your answer. And then because we're talking in anxiety, we're going to do another true and false question. Here goes. You are treating a 10-year-old child who refuses to attend school because of anxiety, has truancy charges filed, and is at risk of removal from parents and placement into a residential group home, where I tell kids, you sleep and go to school in the same building. Okay? Individual and family therapy is already in place for the last 6 months, but there's been very little progress. Starting medication for anxiety is appropriate, true or false. Same thing I just said before. I'm hoping your comfort level will increase answering that question in 45 minutes. Okay, I have no financial disclosures to tell you about. There is a bit of an organization to this talk. Usually my talks have almost no organization, but this one does. We're going to talk about DSM-5 approaches to anxiety and depression, or maybe definitions. And then we're going to talk somewhere in the middle about when to prescribe, and last, what to prescribe. And we'll add some follow-up about some treatment trials. How effective are these meds? Okay, and that's a lot to accomplish in a short amount of time. So we'll dive into anxiety. Most people don't actually have a definition of anxiety, and I'm not going to dive much into it, other than to say that anxiety is not fear. So you probably can't read down here in red, and it's not on your sheet of paper, but it says, next pick, is it fear or anxiety? So we're going to do a Rorschach ink blot test, and I'd like everybody in the room to either blurt out the word immediately, either the word fear or anxiety. Okay? And you have the definition in your handout about fear as it's compared to anxiety. But I bet you can figure it out with this next slide. So did everybody know what they're supposed to do? You're going to blurt out either fear or anxiety. Ready? Here goes. Does anybody in this room think that's anxiety?
I think that's anxiety. I have anxiety.
You have anxiety, but I think I'm talking about his feeling right now. Okay? We all agree that that's fear. That's not anxiety. By the way, the DSM-5 describes both in there. but they're very, very different. Okay? All right. Working towards a definition. So first I have to ask a question. Is anxiety a good thing or a bad thing? Depends. Are there times in life, in everyday life, that anxiety is a wonderful thing?
Yes.
Somebody give me a story. I'll come up with one. I am fearful that the bank will take my home if I don't pay my mortgage. What does that fear make me do? I showed up at work today over that fear. I'm fearful that you'll think I'm an idiot, so I made sure I didn't have boogers before I showed up today. What a wonderful anxiety. Okay? If I go up to my building on the 3rd floor and I walk up to the roof and I stand right on the edge, how do I feel? Fearful or anxious, what does it make me do? So if someone's goal is to get rid of all fear and all anxiety, you have an impossible goal. Okay? And hopefully you know that there are some normal times for anxiety in children's development. We'll dive into that just a little bit. So again, anxiety is sometimes a wonderful, predictable thing. However, sometimes it interferes and goes too far, and it might not be appropriate for developmental age. Let's dive into that. So I've got up there, and I was taught in residency and fellowship that 100% of all infant and toddlers have anxiety. Have any idea what that means? What's a normal developmental step related to anxiety in 9-month-olds, 10-month-olds? What is it?
Strangers and separation.
Separation, stranger anxiety. Completely normal. Would you want to put that kid on Prozac for that? Some parents want Prozac for that. Not appropriate. That's a normal anxiety. Okay? Really important. By the time they go to kindergarten, 10% of children should meet the DSM-5 criteria for anxiety disorder. And it grows over time. Okay? Everybody okay with that developmental approach? Okay, I could give you all of this stuff about how important anxiety is in children and learning how to develop, but this isn't worth reading. I'd rather do another Rorschach ink blot test with you. So this time I'd like you to blurt out if this is normal or abnormal anxiety. Ready? Everybody ready? Normal or abnormal? Do these children need to be on Celexa? Maybe he does. Right? Although I suspect he's already drunk a little bit with this picture. Who knows? Okay, so again, completely normal. You would never medicate this, you would never diagnose this, but occasionally you'll have parents bring you their children wanting a diagnosis for this. And you would do psychoeducation with this. Okay? All right, I like this study because it's Appalachian Mountains. It's actually a North Carolina study, but there were Tennessee Appalachian people. In other words, there were Johnson City people in this enormous study. 1,400 people for 13 years, right? Ages 9 to 26. And about 20% ended up with a full-blown anxiety disorder as an adult. Okay? Risk factors, basically all of them. Since I'm talking to pediatricians today, the one I want to pay attention to is if you have a significant medical disorder, and I think of leukemia, cystic fibrosis, that type of stuff, you're much more likely to have an anxiety disorder as an adult than someone who doesn't have significant medical issues when they're very young. Okay? The other one that I like to point out is overprotection and anxious parents. Okay? And so those would be some of the common denominators in my office. Okay, I'm trying to play a trick on you with this one. Does the person who put this sign up have ADHD? They could, right? They just could be terribly inattentive. What else could they be? A fear of heights. Right? And so every kid that comes to me that's inattentive is not ADHD. They just might have a ton of anxiety. And I'm terribly guilty of diagnosing children with ADHD and missing anxiety. Okay, I think particularly the faster you have to do that diagnosis. All right? Okay, what to look for? Everything, including bad pizza, is a risk factor for anxiety, so I'm not going to dive into this. I still want to point out anxious parents often have anxious kids. Okay, what is an anxiety disorder? Well, here's the new DSM-5 way that we break this up. And what you really need to know is that PTSD and OCD used to be in the anxiety chapter, but now they broke them out and they have their own chapters. Okay? A couple of things became full-blown. Excoriating disorder, which you might call picking disorder, is now a full-blown disorder. In the DSM-4, it was not a full-blown disorder. think that's all I want to say about that. Okay, put on a different hat. Let's move over to depression, unless there's questions about anxiety. Any questions? Okay, let's move over to depression. Is sadness normal or abnormal? It's a wonderful, wonderful, completely normal part of living. Okay, so we've got to figure out, just like anxiety, it's important to be sad over things like death, like failing grades, right? Over the death of a patient. That makes sense. Okay? However, it can be too much at times. So, what separates a disorder from normal sadness? These three things. What you have to figure out what significant is. A lot of times parents' definition of significant is much different than yours. Maybe I should tell a war story with that. So I ran a private practice in Fort Lauderdale for 5 years, from 2000 to 2005, and I only saw the mega rich. I took no insurance, and people just wrote me a check. Okay? And my second year there, at the rich school, the second grade teacher referred all 9 boys. She had the perfect classroom. She had 18 kids, 9 boys, and 9 girls. When you're paying that much money, you have a perfect classroom. And this old battle axe referred all 9 boys with 3s on their Vanderbilts. Hopefully you're like a Connors. So they're all, according to her, hellions. Okay, and I'm starting to realize it's the same teacher, same school, and it's all the boys in the class. So I've already got a prejudice that this isn't ADHD. Okay, so in walks in the first family. Okay, Dad is a world-renowned, Harvard-trained transplant surgeon. Behind him is Mom. She's a Cornell, a judge that had just run in Fort Lauderdale and became famous, and so I know who she is too, and she's from Cornell. And in walks the second grader in a blazer, tie, all that. They sit down. Okay, true story, I'm not making this up. Okay? And they tell me that this teacher has just given him his first B. In preschool, and in preschool, I guess if you pay that much, you get grades. He made straight A's in preschool. Kindergarten, straight A's. First grade, straight A's. What did this teacher do? Gave this kid a B. Is this kid dysfunctional? Is this significant? Everybody in their head, in this room, is shaking their head no. What were these parents doing? You go to Harvard or Cornell if you're making B's. See how their definition of significant or dysfunction is completely different than mine? Okay, I didn't medicate any of those kids. I know several that went and got meds and their kids had better behavior, and the second grade teacher was even happier. Okay, and so I just want to point out, significant is an interesting thing, particularly in my field. Okay, we no longer teach the word depression. We teach it as a continuum. Now when I teach that I'm diagnosing an adult or a teenager or a kid with sadness, I'm teaching, well, you might be here with one single episode of major depression, but everybody's on this continuum of bipolar disorder. So somebody, their first presentation of depression could really be the first presentation of their bipolar disorder. Okay? Have me back for a whole discussion on bipolar. Okay, some words have changed in the DSM-5. We don't use the term dysthymia anymore, which is long-term, low-grade depression. Okay, in adults it's 2 years, in kids it's 1 year. We now use this new term, persistent depressive episode. Okay, by the way, it's much harder to treat persistent depressive episode or dysthymia than typical major depression. We've done away with complicated bereavement. Why? Because there's no good way to describe bereavement in kids or adults because it's different for everyone. Does that make sense? Everybody grieves different. Okay, and so we've just taken folks that become dysfunctional from their bereavement and we've just kind of incorporated them into major depression or dysthymia or persistent. Okay, the DSM-5, the criteria didn't change, and the DSM-5 says the reason the criteria didn't change is because there's so many studies about depression, they thought it would mess up everything. So the DSM-5 is exactly like the DSM-4. And you're supposed to memorize these 9 things, which to this day, I'm still not able to memorize. Okay, I've been doing this for 27 years and I still cannot regurgitate that. Okay? So when I'm teaching medical students or residents, I teach them the next one. And the way I like to describe this is you're in a busy practice and they say, oh, my teenager's depressed, and you start asking about depression symptoms, but you can't remember all 9. Okay, and you've kind of run out of things to do. So I would recommend you run to your ABCs. Have I asked about A? What is A? Appetite. How's their eating? If you're depressed, you're probably eating too much or eating too little. Have I asked about B? What is B? Bed. If you're depressed, you're probably sleeping too much or too little. What is C? Concentration. D is two things, depression, but it's also sadness or death. E is energy. The younger you are, the more likely you're going to have ADHD symptoms if you're depressed. You're likely to become more active. So again, real easy to diagnose a kid who comes in with depression as ADHD because they become more hyperactive. Okay, and you can tell the difference because ADHD is a developmental disorder. They should be conceived with it. Okay? F is the term fun, but a better term is anhedonia. Okay? Generally, even if they're still doing all the fun things they used to do, they don't get the same feeling out of it. And here's the rest. Okay, so if you're documenting in your chart as a pediatrician, I would recommend you document the ABCs of depression. This is a great place to run to when you're trying to figure out, or your attending's in the room and they're watching you. This is really helpful. Okay? Okay, a little bit about depression. How many kids did I say who were toddlers had anxiety? I said 100%. Now look at this slide. What does this say? Only 1 to 2%. And it's tough to diagnose these children. We often use that yucky term that I don't like, failure to thrive. Okay? Adolescents, it's closer to 3 to 8%. You see the rest of the numbers. We can talk all about post-puberty and why the numbers start to separate. Before puberty, it's equal male to female. However, the female's almost double, and there could be lots of reasons for that. And that's a complicated discussion. Okay, I've already said that children who are depressed present a little bit different on average, not always, than adolescents who are depressed. And I won't go through all of those bullets either. By the way, the younger they are, the more likely they're going to give me bizarre kind of hallucinations that are kind of quirky. You know, I see the devil at night, and that kind of is much more common when they're younger than when they're teenagers. Not that it doesn't happen in teenagers as well. Okay? Okay, this is how depression's likely, but not always, but likely to present in teenagers. You're more likely to have thought stuff going on, more issues with suicide, much worse function, and maybe because the consequences of behavior are so much greater as a teenager, maybe that's why that bullet's up there. In child psychiatry, comorbidity is the norm. In child psychiatry, I rarely put one diagnosis down. I'm often putting down 2, 3, 4, and that kind of stuff. It gives us a black eye. Okay? All right. If timing is right, let's see if I should know right where I am. Oh, we're doing great. Okay, so we're going to take, so that was all about anxiety and depression. Any comments about any of that, about diagnosis? Let's do some test questions. Be right there. In order to meet the criteria for major depression, how many weeks do you have to have of those 9 symptoms? On this side of the room. 2 weeks, right? What else do you have to have? Dysfunction in multiple areas.
Has to be like significant.
Significant, but again, significant's a tough term. Everybody has to figure out what that is. Yes, ma'am.
Question about suicidality in
Yes.
really younger ones. I know you said it's rare.
Yes.
Is there an age above, like, is there an age below which you don't really worry about suicide?
No, I would say you worry about it at all ages. Because it's publicized so much, so I just did a research or a review on this about, because they're saying that younger kids are completing suicide more than they used to. That's in the literature right now. The numbers are not really there to back it up. I think what we are seeing is that it's so publicized, so talked about, which I think is a wonderful thing, that younger children are also talking about it more. Okay? And it means we still ask. It's still reasonable to do that. But as far as completed suicides, there's barely any kind of statistical blip. Does that answer
Because
it?
we're seeing younger kids, like you said, expressing it.
Absolutely, me
talking about
too.
it, and we're not sure of how much to kind of
Yeah.
set store.
Completed suicides are very rare below the age of 13. Now that's somewhat of an old comment. I also think that puberty is getting younger and younger, and I'll bet that number's changing with puberty. don't have a better answer. It's a great question. I don't have a better answer for it. I get asked that one a lot. Okay? The youngest suicide I've seen is 14. Okay? Now, that's not a comment about attempts. And I have 7-year-olds who come in and tell me they put a belt around their neck and they yanked. Okay? All right, so we're going to do a little bit of back and forth about treatment. Okay, so there are recommendations on how to treat both anxiety and depression. And so here I have just the American Academy of Child and Adolescent Psychiatrists.org. That's one place you can go. Okay? The American Academy of Pediatrics has theirs as well. Okay? And so we would like for you to be aware of practice parameters, but a lot of people aren't, and they're next to impossible to remember. So you also have just evidence. Oh, and I also want to point out that Tennessee every 5 years puts out their recommendations for behavioral health guidelines. Okay? And I'm going to show you a couple of slides about that. Okay? However, you just might know the research. You know what the evidence-based research is. So that might be a great way to approach anxiety and depression treatment. You might just know what's FDA approved. I don't like that approach, but it's better than, what's the next one? Next one is, oh, you know what? When I was in my residency, my attending only used Prozac, so I only use Prozac. I hear that a lot from pediatricians. Okay? And then in one of my other slides, 5 drops down and it says worstest, because I'm from East Tennessee. I can use that word. What's the worstest way to treat anxiety and depression? Right, trick question. Just ignore it. And a lot of people do. What's the main reason we ignore it? Oh, time. That takes a lot of time. All right? Okay. This is an adult slide, but I think it's appropriate to children. What are you trying to accomplish with treatment? Not just medicine, but you're trying to accomplish eliminating symptoms. Did I say diagnosis? No, I said eliminating symptoms. Okay, I'd love to get rid of the diagnosis too. I'm trying to big time improve function. And what else? Prevent this from coming back. Okay, don't remember this. Okay, but I want you to see practice parameters. This is a practice parameter. There's 10 of them for anxiety. In a minute, you'll see the same thing for depression. I just want to point out, look, it's recommending psychotherapy, number 6, before SSRIs. Okay? All right, this is from the depression. There are actually 16 of those recommendations. Okay, I need to know them. I don't think you really need to know them. But look, I want to read this one to you. Number 8 says education, support. What is support? Is support the cheerleading coach? Yeah. Is support Cub Scout leader? Is support football coach? Is it Sunday school? Is it, just think wide. Support comes from so many different places. Sometimes support is even the courts. I've seen that in many places, many times. Okay, so with education support, case management appear to be sufficient treatment for management of depressed children and adolescents with uncomplicated, which I said is rare, or brief depression, or with mild psychosocial impairment. What does that say? That says don't medicate everybody. Everybody hear that? Don't medicate everybody that you diagnose with depression. Everybody hear that? So I need to say it a third time? Don't medicate everybody who's depressed. That depends on severity, dysfunction, symptoms, and all of that. Okay. All right, this is from the Tennessee guidelines. I think every 5 years they ask some of the experts to get together. What I want to point out is there are lots of drugs up here that are not FDA approved in children. So the experts in Tennessee think it's okay to use non-FDA approved medicine in children. I do it all the time. Pediatricians, family practice docs, get a little uncomfortable with it. Okay? For good or bad reasons. Okay, when I have a panic attack, I put a brown paper bag over my mouth and drink all the rum inside. It seems to help. Why did I put this up here other than to get a laugh? There are lots of ways to treat anxiety and depression that are very effective but very unhealthy. You can think of some examples. This is one. Drinking alcohol will treat panic attacks. I just wouldn't recommend it. Okay? What's another? Think of a really common one. Think teenage girls. Cutting. What does every teenage male or female who cuts tell me about cutting? I feel better. And the parents, they get all uncomfortable and all that. But they do feel better. And sometime have me back and we'll talk all about cutting. So we're asking people to stop doing something that makes them feel better. Why? Because of safety. Because there's better ways to handle sadness and anxiety and frustration and all that. Okay? And so you need to look at, when you dive into treatment, what are they doing to make themselves feel better that's very unhealthy? Okay? And that sometimes that's extra schoolwork. My OCD folks, they do extra schoolwork because of their OCD. And so if I treat them, their grades usually drop. Parents love that. Okay? All right. This is the Depression Tennessee guidelines. Do you see lots of drugs up there that are not approved for children? Because I do. Look at one of those right up there. Well, it's down here. Somewhere up here is anafranil. Well, it's not on this slide. Sorry. We'll get to another one. I'm wrong. Okay. So I need to take a back step because everybody in this room has a prescription pad, and all of you guys are salivating right here. You can't wait for me to start talking about SSRIs. But I need to remind you that there's a non-medical approach. I've already talked about support. Okay, and we don't medicate everybody that's depressed. I've already said that depends on severity and dysfunction. Okay, so here are non-medical things that we do, and there's probably a lot more to this list. I'm going to throw out a couple of bullet points related to anxiety and depression and treatment with non-medicines. Oh, a couple of comments about like CBT or any therapy. It requires, first of all, motivation. It requires parent motivation, assuming the kid's not driving. Right? It requires attendance. They actually have to show up for this. What we often say in our field is that this stuff doesn't generalize. What happens in therapy often doesn't go to the next step, whereas my medicine, you take a pill, it tends to generalize into your entire day. They have to incorporate it into them. Family support. CBT requires some family stuff, particularly for kids who don't drive. And it requires insurance, money, some type of financial support. Okay? In our area, it requires some actual human beings to actually do it. Right? There's very few people that actually do it. Okay, a little bit about cognitive behavioral therapy for anxiety, and I just like to tell a war story. A lot of people around here know Harry Sperling. And so Harry Sperling is 200 years old. He's got gray hair. Harry's not in the room. Hello over there. And Harry is a motorcycle rider. He's the coolest therapist forever. He's been doing it for 40 years. I want to tell you a story about a story he did, true story, with a kid who had OCD that couldn't touch doorknobs or anything that he thought was covered in bacteria. Okay, and this story is maybe 10 years old. So Harry went out and found a coloring book that had like bugs in it, like parameciae and roaches and all that. And it's a coloring book, and this is like a 7 or 8 year old. Okay, so the first time of therapy, they pull it out, and they spend almost an hour coloring this bug, this paramecium, this bacteria. Okay, and this kid makes this thing has like guns and knives, and this kid has made this bacteria really scary. Okay, and Harry suggests to the family and to the kid, I want you to wad this up and put it in the farthest part of your closet and hide it. That's therapy number 1. Okay? Kid comes back a week or two later. This time they pull out 3 pages and they color. They still only have an hour, so they don't spend the amount of time that they did before. But Harry says, will you put it in the shoes in the closet? Wad them up, put them in the shoes. Next time they do 10, you care to put them on the closet door? What's happening, guys? We're moving bugs, his greatest fear, that he's controlled, manipulated with his hand, that he's colored, into his life. Eventually, they tape one on the doorknob. Can everybody see the therapy that's happening here? Okay. All right, I'll move on. You guys look sound asleep. Okay, anxiety in school. So there are lots of ways to treat school refusal, and there can be lots of reasons for school refusal, not just anxiety. Sometimes it's a home that won't ever get them there. Okay? Sometimes it's because I'd rather be out in the parking lot smoking pot. There are lots of reasons why people don't go to school. I'm concentrating on anxiety. Okay? So let's work our way down. Establish check-ins. Usually it helps to have like a school counselor or school nurse where you come in and sometimes even hand over your keys. And the nurse hangs on to your keys till school's out. That can be really effective. Okay? Accommodate late arrival when it's not laziness. Okay? Allow extra time to move from classes can be really helpful. Identify a safe place. What does that mean? Each kid has a place at school where they think is very safe. Some kids, weird ones in my opinion, prefer the principal. That was the last place I ever wanted to go. But they like a place of authority. And if they're overwhelmed and anxious at school, they'd like to go sit in the principal's office for a little while. Most kids want to go to the nurse, the counselor, or the library. And you can set that up, even if you have to with a 501 or something official. Usually I can get away with just a script that says, for the next 3 weeks, we'd like for Johnny or Susie to be able to leave class whenever they choose and go sit in the library. Now, it takes some coordination, takes some effort on your time, okay? Reward efforts, blah, blah, blah. Please don't use homebound. Why do I put that there? And by the way, this isn't just my opinion. All the research says, and my last slide is citing some of the research says, makes it worse. Okay? Now, help them, support them, but don't use homebound. Almost always makes it worse because 2 years later, they come back to me and I'm expected to undo that. Okay? It makes my life a lot harder. Okay? All right, I'll get off my hobby horse. Let's move on. What predicts CBT will work or will not work? Well, these things predict it won't work. Severity, greater anhedonia, hopelessness, sexual abuse, parental depression, family chaos. Okay, I've said this 4 times today. Somebody fill in the blank. When should you medicate? Dysfunction. And again, you have to kind of figure out to what degree. The other thing I would say is that you have to have a symptom that you can medicate. So all day long, I'm asked, Dr. Musil, what are you going to have that's going to make my kids stop arguing with me? And I say, I don't have a medicine for that. I say it all day long. What do you have that's going to make Johnny stop stealing? I don't have a medicine for that. Okay, and it's important to learn that, to learn what symptoms meds treat and don't treat. Okay, I would not medicate the folks on your right. I'm more likely to medicate the folks on your left. The younger they are, the less likely I'm going to medicate, less severe impairment. They've not done any CBT. However, on the other side, I'm more likely to medicate. Okay, here's an example, and it's an answer to one of the things I've asked you to, what's it called, the objectives. If they have mild depression or moderate, they recommend case management, supportive counseling, moderate to severe. See how moderate's in both here and here? The moderate part is the gray part. Okay? All right. Both parameters for anxiety and depression recommend SSRIs first line when it comes to medicine. Do they recommend a certain SSRI? Somebody shake their head, yes or no? They do not. Do they recommend an FDA-approved medication? They do not. Okay? All right. Are all SSRIs alike? This is trying to give you an answer to that, and I need to hold somebody's hand. Will you hold out your right hand for me? Okay. Ki value up here. Ki value is how sticky a neurotransmitter is to a receptor. The lower the number, the stickier it is. Okay, and I should help you with these terms. 5-HT is serotonin, that's norepinephrine, and that's dopamine. Okay, so if you hold that hand back up. Here's a Ki value of 1. Try to pull your hand out. That's 1. There's no way the neurotransmitter, is ever going to let go of this receptor. Okay, this is a Ki value of 5. He might be able to pull his hand out. Now just keep it right there. This is a Ki value of about 1,000. Okay, now, you could add so many of me that even though we all have a Ki value of 1,000, but if there's 1,000 of us around or 100 of us around him, we still could impact this receptor if you increase the concentration enough. Okay, everybody okay with that concept? So you tell me, you can put your hand down. So you tell me, and I need to help you with these words, that's Lexapro, Celexa, Paxil, Zoloft, and Prozac. You tell me from the Ki value if these drugs are all the same. They're actually very different. Okay, so let's test. Which of one of these is the most sticky, has the lowest Ki value to serotonin? Come on, somebody answer. Believe it's Paxil, right? 0.34. Which one's the most sticky to norepinephrine? think it's Paxil, right? Okay, which one of these is a little bit like Concerta or Vyvanse or Adderall? What I'm really asking is, which one of these has a dopamine effect? Did I pull a fast one on you? I'm talking about SSRIs, but I just switched and talked a little bit about ADHD. If you can push Zoloft with a Ki value of 315 up to a high dose, I can get some ADHD effect out of it. Okay? All right, so they're not all the same. The only point I'm trying to make there. Okay, the next 3 slides are very confusing. The best way to approach it is I'm going to take a pie and divide it up into multiple different ways. So here's wedge number 1 when it comes to SSRIs. So pay attention to the top. The most often used SSRIs for anxiety. A TCA is at the top up there. Not that we use it much now, but historically, anafranil has been used for a long, long time in kids for anxiety. Okay, now here comes another piece of the pie, another slice. Now I'm including FDA-approved medications in children for anxiety. What I like to point out is a lot of them don't have FDA approval. Okay, why OCD? Because it's easy research. It's cheaper. OCD is so easy to understand and watch and see, and raters and all that kind of stuff. Okay, so one more slide, another slice of the pie. Now I've included all mood disorders, really major depression, except I left out bipolar, because there are some meds that are approved for bipolar, and we're going to stay as far away from that subject today as I possibly can. Interesting, Cymbalta, you may not be aware, just got GAD approval. Okay, that's an SNRI, beyond the scope of this talk. Okay, most people come to my talks because of this right here. They want to know, when do I prescribe Paxil? When do I prescribe Prozac? When do I prescribe Zoloft? I'm going to barely touch that. Okay, and let's do the next slide. Oh, I already said this. Oh, Musil's approach. There it is. Okay, and this is not original. I'd love to say it's somewhere along the way I was taught it and I've just hung on to it. But what I do is I teach or tell people to pick the SSRI for your 17-year-old or your 8-year-old or whatever you're treating by the side effect that you want. You pick SSRIs, and that's assuming that they're all equally efficacious. And theoretically they are, although I did tell you that their Ki values are different. Okay? And I already said if they're having a lot of concentration problems, gosh, I might pick Zoloft over the others. But we're going to skip that. So when I pick an SSRI, I pick it by the side effect I want. So this is how I teach it. First finger is Prozac. These tend to be more activating. You tend to not gain weight, but there are exceptions. Then Zoloft. These are more activating, less likely to gain weight. The L words, Luvox and Lexapro, are in the middle. They don't tend to be either way. They're hard to predict. My more calming, sedating, and weight gaining are Celexa and Paxil. 80% of the time, I'm right. Unfortunately, kids haven't read the book. They don't always have the side effects that you expect. Okay, so I want to give you a case, and you tell me the drug for this kid, and I'm going to totally make it up. This is a 10-year-old. This kid, 10-year-old, is anxious. When they're anxious, they eat all the time. They've gained 20 pounds. They're so anxious they can't sit. They're always moving. They don't sleep at night. So you're going to pick Prozac, Zoloft, Lexapro, Luvox, Celexa, or Paxil. You want them to gain weight. They're already gaining weight. Lexapro, well, that's almost always a safe answer because it's in the middle. Yeah. So I want to activate them, blah, blah, blah. Okay, so you can see the way you approach this. Is everybody okay with that? Okay. Depending on the amount of time I have is how I'm going to handle the next few slides. We're going to skip past how to prescribe my 3 favorite. So I use a lot of, and child psychiatrists use a lot of Celexa, even though it got the black box or the warning about going over 40 milligrams. Lexapro is used a lot. Zoloft is used a lot. Lately, the literature is saying Prozac over all of them, basically because there's so much more research on Prozac and because of the black box warning, which we're going to get to. Okay? I would recommend not knowing one, because then you can't pick them by the side effects. I think you need to know 3. I don't care if it's Prozac or Zoloft. I don't care if it's Celexa or Paxil. I don't care which L word. Okay, but I think you need to know 1 in each category. Okay, so we're just going to blow through these because, frankly, they're in your handout. Celexa, Lexapro. We probably need to talk about this. Let me go back for a second. So, citalopram is that word down here, but it's got an ES in front of it. What does that mean? You put that right hand out again. Right, it's racemic. Okay, so they're stereotypic. So, first of all, Celexa has Lexapro in it, but it has both forms, chemically exactly alike, but they're mirror images. And again, the hand works here. This fits great. This is Lexapro, just has the right-sided. This is Celexa, has the awkward one and the right one in it. To me, they're very different drugs. Okay? All right. And the FDA would say they're very different. So we're going to blow past these. I think this is beyond the scope of this presentation. Okay, is Wellbutrin an SSRI? No, it works on norepinephrine and at bigger doses dopamine. So if you want to make an anxious kid more anxious, give them some Wellbutrin. I see it all the time. I get referrals all the time from folks. Oh, I gave them Wellbutrin. Diagnosed with anxiety, I gave them Wellbutrin. Now, there are exceptions. I will sometimes add Wellbutrin to an SSRI. Every once in a while, Wellbutrin doesn't increase anxiety. It's effective. But generally, increasing norepa and dopa is going to make somebody more anxious. Okay? Great depression drug, particularly if they have ADHD. Remeron's very complicated. It doesn't really work at the end of the synapse. It works along the synapse. Strattera was developed to be a depression drug. It didn't work, so they somehow got it approved for ADHD. And let's skip the rest. Okay, back to that other objective, other classes that are effective for anxiety. So I heard on NPR, you know how research-oriented the NPR is, that 2 tons of Benadryl is taken every night in America to help people sleep and help with anxiety. 2 tons a day. All right? And so a lot of us use hydroxyzine or an antihistamine, particularly PRN, for anxiety. I will sometimes even do that for school refusal because if I send them to school, it's hard to be anxious if you're exhausted. At least you've got them on site. Right? And sometimes sleeping through school is better than sleeping at home. You're going to have to kind of figure out your wars. Okay? But here are all the other classes. I use a ton of 10X and clonidine. Cabban and Tuniv are just retail drugs of those. Buspar. I never use benzos. Wouldn't recommend you ever do it. Send those folks to me. Okay? It's just not it's an easy thing to do, and it always works, but you're going to pay on the back end, and it often disinhibits them. Okay, what does that mean? That's me and alcohol. I never talk about women's bodies until I drink. It disinhibits me, and then I start talking like that. That's what benzos do. It disinhibits. You're more likely to rage and tantrum on benzos. Okay, let me prescribe those. You're probably aware when we have OCD and they're not responding well, we add Seroquel. Again, all beyond the scope of this. I just want you to know we use other classes besides SSRIs. What will they do? They help us a lot with sleep. By the way, they have a 70% chance of helping. 70% chance you'll come back and think I'm a great doctor. 30% chance you'll think I'm terrible. Okay? Typically helps with anxiety. These drugs are much better for anxiety than they are depression. Okay? And I probably should ask the question, do SSRIs make you happy? What makes you happy? What drug makes you happy? Say again? Couldn't hear you. Ritalin, maybe. I think the best answer is meth or coke. Methamphetamine or coke. What's my point? I don't have a happy pill. And I certainly would not recommend methamphetamine or coke because of all the side effects and all that. So, if people's target symptom is happiness, should you medicate them? It's an impossible target symptom, and you will never be successful as a prescriber. You need to come up with a symptom you can treat. Oh, I can help your sleep. So it begs the question, what does make people happy? If I don't have a happy pill, what makes people happy? What's the root of the word happy? Hap, H-A-P. What does hap mean? Come on, somebody be a... It means happening. So if I play the lottery today and I win a gazillion dollars, how will I feel? Pretty freaking happy. Right? But if I get a call today and one of my three kids has leukemia, how will I feel? Pretty freaking sad, no matter whether I'm on Prozac or not. See the difference there? You have to figure out the appropriate target symptom for these meds. And so if you have a teenager or an adult who says, prescribe me something that makes me happy, and every time you see them, it doesn't make them happy, you're never going to be successful. You've got to come up with appropriate target symptoms and put them into the chart. Okay? All right. I think we've made all these comments. What they won't do, and I want to talk about this one right here. Stop a bad situation you're in that maybe even cause or is causing your depression. It might allow you to stay there longer. So I'm terribly guilty. Let's pick on housewives. Housewife comes to me. She's in an abusive relationship with her husband. She's depressed. She hates her marriage, blah, 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 but she's not leaving. She meets the criteria for depression. I give her Lexapro. She comes back and tells me I'm better. She feels better. Have I helped her? I don't think I have. Okay, now I've made money on her. I've appropriately diagnosed her. I've appropriately prescribed, but have I helped her? I don't think I have. And I'm guilty of that. Our whole profession is. Okay? Okay, let's keep moving. Side effects, this is more specific to children. I'm asking you to know at least 3. You have more serotonin receptors in your gut than you do anywhere else, so watch out for SSRIs and gut symptoms, particularly with Zoloft. This is an adult slide. Either we didn't ask, or we're too embarrassed to ask, or they're too embarrassed to tell us about sexual side effects. So it's hard to find any real research out there about teenagers and sexual side effects. Okay, black box warning. I guess I'd rather just tell a story to get this out there. So when I was a medical student, when I was in my residency, I was told every so often kids get worse on SSRIs, they get more activated, their mood's not better, and so if you've got more energy and you felt like killing yourself all the time, you go attempt. That's what I kind of always heard. Okay? None of those studies were powered enough for that to be statistically significant. So you'd see one case here, one case there, but we were all told this. Then UK ruined this. Okay? They did a study with 1,000 teenagers. In order to be in the study, you had to say you'd never had thoughts of suicide. So this is over in England. Okay? That's in a huge study. We don't have any studies like that here. Okay? A computer randomized them. 500 of them, these are all depressed kids, went and saw a therapist. None of them had thoughts of suicide before. How many of the teenagers who had depression, who never had thoughts of suicide, after they got to know their counselor, started having thoughts of suicide? Somebody guess the number or the percentage. It's 2%. And if you think about that, that really makes sense. Right? You're probably having those thoughts, but you're going to deny them. You get to know your counselor, you get some trust going, and you share. So you could say that therapy 2% of the time causes thoughts of suicide. I don't agree with that, but you statistically could say that. And that's enough kids. It's statistically big enough to statistically say that. 500 kids. Okay? So the other 500 got counseling and Paxil. They like Paxil over there. What percentage of them had thoughts of suicide in that study? 4%. It doubled. They packed up that information, they sent it over here, and everything kind of blew up. Okay? That's the basics behind it. Do we fully understand it? No. What I like to, I want to point out this site. This is still a site that's available. parentsmedguide.org. If you put in .com, it still gets you there. It's handouts both in Spanish and English, all about SSRIs, about ADHD drugs. It talks all about the black box. I think it's very protective to put in the chart that you handed this out, and you can print it out. Okay? All right, ever since the black box warning came out, and I can't remember what year it was. Anybody know? I don't remember. So suicide was on the decline. Somebody may have said it.
2000.
See, it's the two, I just don't, yeah. So suicide in America in teenagers was headed down, black box warning. And what has happened ever since? It's still on the incline ever since the black box warning. Why? Probably delay in treatment. Probably because pediatricians and family docs who were so comfortable are now less comfortable. Okay, and the way I do that is everybody has my cell phone and they call me up. And they kind of get approval. And so I still think it's very appropriate for primary care to prescribe SSRIs. But discuss the black box warning with them. Hey, sometimes people get worse from my treatment. Effective medicines have effective side effects. Worthless medicines have worthless side effects. Should I say that again? Effective meds have effective side effects. Worthless meds like Buspar have worthless side effects, very few side effects. Okay? If we have time at the end, we'll talk more about black box warning. Maybe you should lay off the antidepressant. What's my point here? Watch out for mania. Watch out for activation. I don't know that I'm going to have time to talk about long-term studies in anxiety and depression. I got about 2 or 3 minutes. Let's just do this. Let's look at the number over here. 488 kids. Let's look at the results. So this is sertraline, this is Zoloft, this is sugar, this is cognitive behavioral, and these folks got both at 12 weeks, at 24 weeks. At 24 and 36 weeks, they were all about effective, all about equal. However, combo wins. Okay, this is an anxiety study. I'm interested in you seeing the timing. 3 months. 3 months. You guys are pediatricians. You're used to ear infections being better in 10 days. You've got to have a different mentality. You know, I did a triple board program where I had to go back and forth as a pediatrician and a psychiatrist. It was very hard for me to make that transition when it came to timing. Okay, everything gets better in peds, right? 98% of the time, even if you don't treat them often. Okay, it's not so true in psychiatry. It takes a long time to get improvement. Okay, there's a little bit more about timing when it comes to anxiety. Let's go to the depression. TADS, we all call it, treatment of adolescents with depression. Another big study, 439 kids. By the way, they allowed kids into this study if they had thoughts of suicide. It didn't kick them out. Okay, this was a Prozac study. It's not on this slide, it's in the next slide. There's response rates. Okay, let's finish up here. Want to just remind you about pregnancy. The other day, I had a teenager who I'd worked with for 5 or 6 years, and frankly, everything we'd done at Frontier didn't help her. All my meds didn't help her, but there's one thing I did that did help her. I refused to medicate her unless she went on birth control. And so I actually bragged about helping this young girl only because I had forced her to go on birth control to go on my med. She was so impulsive and so likely to get pregnant, I just said, Now, everybody has to kind of figure out where they are on that. Okay, and I'm not saying you have to be on a birth control form in order to be on SSRI, but you sure need to discuss it. Okay? I've already preached about target symptoms. Okay, this is a common problem, particularly with adults and I guess older teenagers. As you go from a child, where hopefully you grow up at Disney World, and you become junior high, where you want to be just like everybody else, and as an adolescent you start to figure out you're just not like everybody else, and life is hard, you would like to get rid of your feelings. And so I'm frequently asked to get rid of feelings, a terrible target symptom. Okay, but I'm frequently asked to do that, particularly in the days when we diagnosed everybody with bipolar disorder. Okay, why don't they work? SSRIs, compliance, wrong target symptoms. I think they only work 70% of the time. What is considered improvement? 50% improvement. That's a hard one, because what parent, what kid wants to only get 50% better? Okay, we're going to skip effect size. Anxious people are scared to take medicines, so start ridiculously low doses. I like to tell them, break it into 1/100th and put a little wisp in there. And do that for as long as you want. And when you trust that, go to 1/10 and throw, it's ridiculous, it's worthless, but what are you doing? You're building trust. It's a lot better than every time you see them changing it because they had every side effect in the book. Okay? Medications do not create safety. Kids go to the ER, oh, you have an appointment with Dr. Musil? I know you're suicidal, but go see him tomorrow. He'll give you a medicine that makes you not suicidal? It happens all the time, even within my own Frontier system. Okay, meds do not create safety. They might increase safety issues in the beginning. Okay, how long to medicate? This is the book answer, 6 to 9 months for depression, longer for anxiety. The truth is, you medicate until they're ready for more trouble in their life. And I ask them, when are you ready? Often that's Christmas or summer. Okay? Never recommend lifelong treatment. of children. What's the only cure for anxiety? This is a real question. There is a cure that's 100% effective with anxiety and fear. Say again? Death. But no, that's not the right answer. Starts with a T, ends in a T. Come on, somebody can get there. Trust. It's a cure. Most people eaten up with anxiety don't trust anything, and a lot of times they have a good reason not to. Talking about PTSD and trauma-informed and all that kind of stuff. Okay, whole nother talk. Okay, I want to point out that I have not been talking about broken heart. Major depression is not broken heart, something that I think we all understand in this room. It's very hard to define. Bring me back if you ever want me to talk about broken heart. Medicines don't fix broken hearts. In 27 years, I've never medicated or effectively medicated a broken heart. Okay, this is my summary stuff. Consider medicating when the severity and dysfunction. Know at least 3 SSRIs. Know something about school. Know how to refer. Target symptoms, target symptoms, target symptoms, target symptoms. I can't say it enough. Teach people. I've gotten much more rude about teaching people about 50% improvement. So when they come in and they say, Johnny, he's at school and he's got ADHD and the principal's calling me 3 times a month, I'll interrupt and say, well, if we decide to medicate him, it's going to go to 1 or 2 a month. Oh, they're not happy with that comment. I'm starting to teach them what is 50% improvement. Okay, I'm starting to negotiate target symptom improvement. And all the ADHD studies out there consider improvement on the Connors or the Vanderbilt. If you get 50% improvement, they consider that a response. You just have to take that and make it clinical, make it show up in your office. And you've got to teach them what is 50% improvement. Okay, and I told you I'd give the site for school refusal. Okay, let's do the questions I was supposed to give you. Starting a low-dose SSRI for depression is a good first-line treatment for mild to moderate depression in a child. According to what we just discussed the last 45 minutes, what's the correct answer to this question? False, because I slipped the word mild in there. Okay? All right, you're treating a 10-year-old, and I'm not going to read it all over. Should I medicate, or starting medicine is a good idea? True or false? I consider this kid terribly dysfunctional. He's about to be sent off to a group home. CBT ain't working. I would medicate this kid. If you don't, refer him out. Okay? Okay, questions, or I love a good joke? And I think we have, sorry, we only got 3 or 4 minutes. Usually I give us 5. Yes, real loud so everybody in the room will hear it. And that's not me, right? No.
Mortality and any therapy that can decrease mortality in depression.
So
Talk
death.
about ideation.
Yeah.
But what about actual suicide?
There's only been one drug that's ever been proven to decrease the risk of suicide.
It doesn't have to be drug. It can be
Yeah, but let's go there. Let's go drug and then we'll go another direction. What's the only drug that's ever been proven to decrease completed suicides, risk of suicide, however you want to put it? You're not going to like the answer. Starts with an L. Lithium. Okay, now, are we specifically asking that question anymore, and are we researching that question? We're probably not, so it may not be a fair comment. So are there other therapies that decrease suicidal thoughts or suicidal completion? I don't know of a good one. I would say a good safety plan does. And so asking about weapons and are you locking up Tylenol and all that kind of stuff, I think is the better answer. I've got other experts in the room. Let's ask them that. Are you guys aware of other therapies that will decrease suicide or create more safety? Is there a better answer to that? Yes, sir.
Sometimes social interventions like a hotline or
Oh, I like that. It's a great answer.
having a safe adult they can talk to, really trying to make sure they have a safety plan,
Okay.
I think is going to be effective.
Thank you. Other questions? Yes, sir.
Work.
Yeah.
Is work a reasonable therapeutic intervention?
Oh, I love it. But you're talking to a group of functional people. I mean, when I have a terrible day, you know how many times when my kids were young, I couldn't wait to go to work Monday morning? And so, yeah, putting people back into function is a wonderful thing. Now, you got to be careful. They got OCD and all that kind of stuff. You really could just be heaping on more. So there's a right answer to that. You know, if a kid or an adult goes through a terrible trauma, do you want to tuck them away and let them sit around for 6 months? No, you want to get them into safety and routine as fast as possible. And so if their routine is work, I would get them back to work. Or in this case, back to school, if we're talking kids. Yes, sir?
I would just make one comment that hospital homebound, that's a big deal, but online school is becoming a very big deal.
Huge. And the public schools love it.
They love it. They can get rid of kids that are difficult or not doing well.
And make the money. They continue to get the meds with it, too.
So let's watch out for online.
I completely agree with you. Yes, sir. Yes, ma'am.
Exercise part of.
Oh, what's more effective, an SSRI or any exercise program? Exercise always win. There was a great study 2 years ago on New England Journal of Medicine, all adults, 3 days a week you had to work with an exercise guru, the others got SSRIs. Exercise won big time. So much more effective than any of my meds. Now, getting people to do it, whole nother issue. All right, I would say good decision making is more effective than any SSRI. Right? Mental health hygiene is more effective than any SSRI. But generally people are coming to us because they have issues with that to start with. And part of what you need to do in the system around you is educate them on the more effective things than the SSRI. Okay? Unfortunately, because we have prescription pads, we tend to approach it with our prescription pads, which is really not the best thing. And culture's pushing us. They want us to medicate and not do all those other things. But I'm preaching. Other questions, comments, good jokes, bald jokes? I collect bald jokes. Yes, there's a bald joke.
Yeah, did you hear the joke about the skunk?
No.
Oh, never mind, it stinks.
Boo. Let's see, let me think of a bald joke. I think I've told this before. How do you identify a bald eagle? You comb all your feathers to one side. Anyway. All right, I'm done. Thank you for your attention, and good luck. Thanks.